Thanks for joining us for DermTube Daily Coverage here at Maui Derm. We're with Michael Gold this morning, and Michael gave a presentation about what's new in the use of neuromodulators and fillers. So he's going to be talking to us a little bit about his updates. So can you tell us what you focused on your presentation?
So yesterday here at Maui Derm, we sort of did an overview of some of the current toxins and fillers that are being used, and sort of honed in on a couple of them that are on the newer side, little differences. So, and looked at sort of what makes them, especially on the toxin side, what makes something a little different. So, for instance, when you look at the clinical studies, and you were involved as I was in Xeomin versus some of the others, we had a different bar. I always like to say the FDA sort of raised the bar on that one. So not only did we have to have a 2-point correction on the physician evaluation, but we needed a 2-point correction or improvement for the patients as well.
So that composite improvement is something that's a totally different landmark for people to focus on.
Right. So when you look, and again, I like looking at the studies, and you're Mr. Study for me. You know, when you look at the Botox studies, it was a 1-point improvement. When you looked at the Dysport studies, even though it was a 2-point, it was 2-point physician. Now for the Xeomin, it was actually a 2-point physician and patient. So the bar was just that high. And so when you look at the numbers, composite, it wasn't as great as you might have expected from the Botox and Dysport. Now, does that mean it doesn't work as well? And that was sort of the crux of everything. If you look at another study that was done using a 1-point correction with Xeomin, the numbers were exactly the same as what we got with Botox and Dysport. So again, not one better than any other. It's just the bars were different. And I want people to understand, as you do, that it's okay to have different bars, but you have to put it all in perspective.
So I think really there has been an evolution of specific primary endpoints in a lot of these clinical trials. Right. We saw it with the Xeomin trial for the first time with neuromodulators, a 2-grade improvement. And then when Botox got the FDA approval for the lateral canthal rhytids and the crow's feet, they were subject to the same 2-grade improvement.
And now we're looking at a global Allergan Botox thing where we're doing forehead, crow's feet, and glabella. And again, it's 2 points, patient and physician. So there, again, the bar is up there. And if you have to sort of look at all the studies at what these endpoints are. And that was the major part of the neurotoxin talk.
And I think that this is something we're seeing throughout dermatology. So from a topical perspective, I think the Mervaso clinical trial was the first one to incorporate something very similar, where there was a physician improvement, patient improvement, and there had to be a composite improvement in order to actually demonstrate efficacy.
So if you got a 2-point physician improvement, but the patient only did a 1-point improvement, that's a patient failure.
Right.
And we know in practice that's a great result. But again, in trials it's a little different. And so that was that was the big focus yesterday.
So you also spoke about fillers. Can you tell us about, did you focus primarily on endpoints, or did you talk about some of the rheology and the characteristics
So we talked about all of that. And again, part of it is, you know, what does G prime mean? Does it matter? What does the rheology matter? Is it important? And I think for the sake of argument purposes, having a high G prime is a great thing if you want to have a volumizing filler. So you look at the Voluma, Perlane, Radiesse numbers, they're really high G prime. Radiesse is really high, but when you dilute it with lidocaine, it becomes similar to some of the others. But you also then look at things like Belotero, and you know, we call a soft filler, and where its uses are, and compared to Restylane Silk, which we now have on the market, and so forth. So we try to sort of look at the fillers and say, you know, what are the differences? Where are the best indications for them? Is it okay to use Radiesse and Belotero together, or another filler and another filler at the same time, and how to do that? So we focused a lot on that part of it as well.
So I think at this point we have 3 wonderful companies who've really brought to the market great products that are out there, and I think we all pick our favorites based on specific regions. And you know, you're talking about lift capacity in the cheek or off-label in the temple, and then you alluded to, you know, there's areas where we have fine lines. So in terms of your favorite product to use for fine etched-in lines, what do you like to use?
So up until maybe 2 weeks ago, I was a Belotero only user around the mouth. I still like Belotero a lot around the mouth. I think it's just easy to use. I use a lot of Juvederm and I use a lot of regular Restylane, but now I have Restylane Silk on the market, which is a fascinating product. And didn't talk much about it yesterday, but I used it a lot and was part of the trials for the approval. It is an incredibly hydrating filler. So you can't over-inject Restylane Silk. And we talked about this of just, if we need 0.2 cc's or 0.3 cc's sometimes, we don't think we're injecting a lot of filler. But with Restylane Silk, a little goes a really long way.
So I agree with you, and that's why I asked the question. I think at this point, right where we are right now, Belotero has been a wonderful product in terms of fine etched-in lines, and I think most of us are very comfortable using that. And you really get a good effacement of some of the fine lines, right, especially around the mouth.
And one of the things right now is we don't have lidocaine in our Belotero, so a lot of people will add lidocaine. I don't, for the most part. On occasion I will. But soon we will hopefully have Belotero, a whole line of Belotero products with lidocaine. We know they're coming. And so it's at least something exciting to look forward to have different volumizing fillers that are HAs in Belotero, some that are, again, all with lidocaine, which will just be a great addition for us.
So Restylane Silk is something I think we're all excited about using. In my fellowship in Canada, years ago, we had it as Restylane Fine Line, and it certainly took a long time to come here. But from a standpoint of being able to do something different, it is incorporated with lidocaine. We do use it for more fine lines. It's great for the radiating cheek lines and the secondary smile lines. So just walk us through some of the areas where you like to use different products.
Well, as you said, Restylane Fine Lines has been in Canada for 16 years. So it's really amazing that it took that long for it to come here, but it did. And I think, as you said, it has lidocaine, so it's nice. I like using Restylane Silk, especially on the vermilion border and the oral commissure regions. I think it's a great product. But again, if you overdo it, the swelling sometimes is immediate, and by the time your patient leaves, you're sort of looking and going, what did I do? So you have to use it. You have to learn it, and once you learn it, I think it's a great product. As I said, around the mouth, I'm a Belotero Restylane Silk person now. I use a lot of Voluma and Perlane and Radiesse in the cheeks. We are doing more volumizing. That's the new word. That's our Google word of last year. So we're doing a lot more. So treating the nasolabial folds used to be, I take my Juvederm or my Restylane and I'd put it here and I was done. But we realized, as everybody did, that we were missing. So if you actually lift the cheeks properly, you efface the nasolabial folds. So I actually, as you do, and most of us are now looking at, we're not looking at the folds, we're looking at the cheeks, and we're saying, hey, a little bit of volume can go a long way to improving the everything, and don't overdo it. And again, and that's part of what I always look at these studies that you were involved in and I was involved in. The Voluma and the Restylane studies, we use 6-7 syringes, which isn't real. I mean, in the real world, nobody's going to spend that kind of money. So we're doing 1 syringe, 2 syringes at the most on people, but we're getting great results.
I agree. I think a lot of those studies, when you have, quote, a full correction study, people tend to use a lot of product. And when you're trying to make a point about how long the tissue residence time of a product is, there's definitely an impact for how much product you put in there.
If I put 7 cc's in my cheeks, it's going to last a long time.
So I think one thing that we definitely see from the clinical trials is when you volumize one area, you may be affecting another area, and that was something that was seen in the Voluma trial, where they scored people before in the nasolabial fold, they scored their actual grade of line or grade of volume loss in the nasolabial fold before Voluma was injected in the cheek and after, and people by and large went down significantly along the nasolabial fold.
And I think that also that showed in the Perlane mid-cheek studies as well, so we'll see that. And I think the other thing that we talked about yesterday as well is Radiesse in the hands. And what it's used in, and Sculptura, but Radiesse in the hands, and I know you were involved in the in the grading scale system, and I was involved in the clinical work on that. And in 2015, we're going to sort of announce all these results.
Yeah, I think really people are going to start focusing a lot more on the hands
Right.
once we have the ability to market to that area.
And I think that'll be great.
Thank you so much for joining us.
Thanks.
Good to have you. And thanks for joining us with DermTube at Maui Derm.